Right now, about 11% of US adults are taking a GLP-1 weight loss drug.
Which is staggering.
And even as unit prices fall and manufacturing scales up, employers are spending more, not less.
Because in healthcare, costs rarely disappear, they migrate.
That's the theme today. We're looking at the SWFT Healthcare Intelligence Brief for mid-July 2026, and the whole thing reads like whack-a-mole.
You push down spending in one channel and it pops up somewhere else. So if you're planning for 2027, the trick isn't spotting a price cut. It's figuring out where the pressure moves next.
Start at the safety net, Medicaid and the Affordable Care Act.
Because instability there rolls straight into the commercial market.
Let's take the recently paused 2026 ACA rule from the prior Trump administration. No politics here, just mechanics.
The provisions included tighter subsidy verification, higher out-of-pocket limits on bronze plans, and looser network standards.
Those changes matter because they reshape the risk pool, make enrollment harder or coverage thinner, and healthier people are more likely to walk away.
Then the insured population gets sicker, more expensive, and more utilization heavy.
And providers feel it fast. HCA reported a $400 million hit in the second quarter of 2026 alone, with a projected $1.1 billion annual impact tied to these kinds of ACA coverage losses.
Medicaid has its own version of the same problem. Elevance is exiting Washington, D.C.'s Medicaid program and expects more state exits over the next 12 to 18 months.
At a negative 1.75% margin.
Which gets back to post-pandemic eligibility redeterminations. During the pandemic, Medicaid paused its normal checks. When that ended, states had to re-audit the rolls.
So people who no longer qualified came off, leaving a sicker group behind, but payment rates were often built on older assumptions and didn't catch up to the concentrated acuity.
Same lesson. Government pays less, but the cost doesn't vanish.
It lands on providers.
And then on employers through cost shifting.
Hospitals still have to keep the ER staffed, the scanners running, the surgical teams in place.
The lights stay on.
So when they lose money on uninsured care or underfunded Medicaid volume, they push harder on commercial reimbursement.
Which means safety net instability becomes a hidden tax on employer-sponsored coverage.
And providers are also finding other ways to replace revenue. That brings us to the proposed 2027 CMS Medicare changes.
A stick and a carrot.
The stick is a physician reimbursement cut of roughly 1.19 to 1.68%.
Not great when staffing and overhead are rising.
The carrot is a 32% payment add-on for physicians participating in accountable care organizations, or ACOs.
An ACO is basically a network of doctors, hospitals, and specialists coordinating care for Medicare patients, with shared savings if they avoid unnecessary downstream costs.
And the brief says the model is working. In 2024, 75% of shared savings program ACOs earned $4.1 billion in shared payments, and Medicare still saved $2.5 billion net after the bonuses.
The ACO REACH model also showed strong results across 2.5 million beneficiaries.
But small independent practices may not have the infrastructure to play that game.
Right. Care coordination, analytics, reporting, administration, that's expensive.
So if you're a smaller practice taking a fee cut and you can't access the ACO upside, you look elsewhere for revenue.
Which helps explain what happened under the No Surprises Act.
The law was meant to protect patients from surprise out-of-network bills at in-network facilities.
Reasonable idea. The patient doesn't pay. The insurer and out-of-network provider go to arbitration.
But the brief says that arbitration system has turned into a battleground. A federal judge dismissed Elevance's third lawsuit against Halo MD over exactly this issue.
And three groups, Halo MD, Team Health, and SCP Health, accounted for 44% of all arbitration disputes in the first half of 2025.
That's not a narrow exception process anymore. That's a reimbursement channel.
Especially if a staffing group stays out of network and forces payment fights into arbitration, where awards may come in above standard in-network rates.
So again, the cost moves. Public payment pressure on one side, arbitration-driven commercial costs on the other.
And employers fund the spread. United Health posted a $5.5 billion profit, up 62%, but commercial plan costs were still above expectations. The brief points to out-of-network arbitration as one driver.
Now, the biggest migration in the brief may be clinical, not administrative.
GLP-1s.
Care moving from the operating room and hospital to the pharmacy counter.
The Gallup numbers matter. 15% of U.S. adults have used a GLP-1 for weight loss, and 11% are using one right now. That's up from 3% in 2024.
Employers are nervous, and you can see it in the restrictions. 36% still cover the drugs, but 95% require strict prior authorization. 90% require a high minimum BMI, and nearly 30% require a mandated lifestyle modification program.
And even with all that friction, 10% of employers plan to drop coverage entirely by 2027.
So here's the puzzle. If prices are coming down, why are budgets blowing up?
Demand shock. In a normal market, lower price means cheaper access to the same product. Here, lower price expands the number of people who can realistically start therapy.
So any discount on the unit price gets overwhelmed by the jump in volume.
Exactly. And there's also a timing problem. Advocates correctly argue these drugs may reduce cardiovascular events and reduce the need for bariatric surgery or joint replacement later.
Real offsets, but delayed offsets.
The pharmacy spend hits now, every month. The avoided event may happen years later. And the employer paying today may not be the one that benefits later because employees change jobs.
So employers are pressuring insurers to go after the middlemen, especially PBMs.
Which raises the question, are middlemen really losing revenue or just moving it around?
The brief points to the FTC Caremark settlement with up to $8.5 billion in consumer savings over 10 years, plus another $4.5 billion from point-of-sale rebates. The push is toward rebate-free, lowest net cost formularies.
Meaning less of the traditional rebate model, where manufacturers pay for preferred formulary placement, and more emphasis on the lowest real upfront price.
The brief also says insurers eliminated 6.5 million prior auth codes, an 11% drop.
Sounds great until you ask what replaced them.
Retrospective denials.
Right. Fewer front-end approvals doesn't necessarily mean less friction. It can just mean the claim gets reviewed after the service is provided.
So the doctor treats the patient, sends the bill, then the payer's software asks for records and audits the claim against strict criteria.
And if the documentation isn't exactly right, payment gets denied after the fact.
Which means the burden moved from the front office to the billing department.
Same idea with PBMs. If rebate revenue shrinks, vertically integrated firms can recover economics through other fees, specialty services, or analytics charges.
Which is why the brief says transparency doesn't always equal savings.
Sometimes it just means you can see the invoice more clearly.
So is there any part of the system where this can be fixed, not just squeezed?
Maybe. The brief points to dual eligibles.
These are the roughly 12 million Americans enrolled in both Medicare and Medicaid.
And the spend is concentrated. They're 15% of Medicare enrollment, but 29% of Medicare spend, about $127 billion. On the Medicaid side, they're 13% of enrollment, but 30% of spending, about $241 billion.
For a full benefit dual eligible, Medicaid spending alone averages more than $27,000 a year versus less than $6,000 for a standard Medicaid beneficiary.
The point isn't just that these patients are medically complex, it's that the system around them is fragmented.
Long-term care in one silo, pharmacy in another, acute care through Medicare, wraparound services through Medicaid, poor coordination across all of it.
Take the brief's kind of scenario. A patient with early dementia and untreated behavioral health needs. Because support at home is fragmented or underfunded, the patient has an episode, falls, and goes to the ER.
That acute hospital care is billed to Medicare.
Then the patient loses function and gets discharged to a skilled nursing facility, and that long-term cost falls back on Medicaid.
So a missed lower cost intervention upstream triggers expensive downstream spending across two disconnected budgets.
Which is why the opportunity belongs to the integrators, the organizations that can manage across those silos.
If you can keep that patient stable at home, you may prevent the Medicare ER visit and the Medicaid nursing placement.
And if you can solve that dual eligible puzzle, you've built a serious risk management engine.
So let's end with three practical moves for employers and payers making 2027 decisions.
First, run a risk pool exposure analysis. Know how ACA and Medicaid changes in your market could affect local commercial contracts.
Second, build a true GLP-1 total cost model, not just drug price. Model uptake and the timing of any downstream medical offsets.
Because the bill arrives now.
Third, demand a claims friction dashboard. You need visibility into retrospective denials and arbitration, not just prior auth counts.
And one last thought from the brief: the AI arms race in administrative healthcare.
A little grim, but important.
Insurers are using AI to scan and deny claims on the back end. Provider-side billing firms are using their own AI to generate large volumes of No Surprises Act arbitrations and appeals on the front end.
Bots fighting bots.
So the real question is whether that creates efficiency or just a faster, less visible layer of administrative friction.
That's the question to keep in mind.
Look past the headline price cuts.
And keep asking where the costs migrate next.